Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at La Clinica de la Raza for being the anchor clinic and hosting today's session, Low Back Pain, High Value Primary Care Approach with Dr. Carrie Horwitch. Dr. Horwitch is a board-certified internal medicine physician. She graduated from the University of Arizona College of Medicine and completed her Master of Public Health at the University of California, Berkeley. She's worked as an outpatient primary care physician for over 30 years and worked with the internal medicine residency program for 20 years. She's also credentialed as an HIV care specialist. Dr. Horowitz is active in various medical specialty societies and advocacy, including leadership roles. Her areas of interest are clinician well-being and professional fulfillment, teaching and education, HIV care, and general intern medicine. With that, Dr. Horowitz, I will bring up your slide deck and turn it over to you.
Thank you so much, Kristen, and welcome everybody. This topic, I'm going to try to focus probably most on a little bit of acute back pain. The reason why I'm sort of saying most is because a lot of the data by the studies that I'm going to present to you actually kind of mix a lot of the different types of back pain for this discussion. But what I'd like to do is discuss a little bit of the differential diagnosis, a little bit of how to do a workup, look at some discussion of red flag signs and symptoms to be aware of, and discuss high value care imaging, as well as some of the treatment options for low back pain. So again, we're really going to focus on low back pain. I think other parts of the back, cervical, spine, and everything would probably need to be its own talk. Just because it's, again, a little bit more complicated and there are some differentials within that. Let's go to the next slide. So when we talk about acute, subacute, or chronic, these are the definitions, and it is by time. So acute pain is pain of duration of less than 4 weeks. Subacute is 4 to 12 weeks, and chronic pain is somebody who has ongoing pain of greater than 12 weeks duration. Next slide. So what I like to do is try to get a little bit of interactivity. So if you could type into the chat, in what percentage of US adults will have at least 1 day of low back pain in the past 3 months? If you take everybody who comes into your clinic, how many of those people, what percentage will have low back pain at least 1 day in the past 3 months? So if you guys want to type in chat. Okay, so I'm seeing pretty high rates in the chats of 50 to 75%. Next slide. And actually, it's about a quarter. So yes, it is very, very common. And the reason why we may think it's actually higher is because by the time they come into the clinician, they've already probably had back pain for more than 1 day and they're worried or it's severe and they really don't know what to do. A lot of people will have back pain and do not come into the healthcare clinic. So when they do come in, we do need to pay special attention to what's really going on. Let's tease out, are there any red flag symptoms? Or is this acute mechanical low back pain? Next slide, please. So I realize this is a pretty small chart. It does come from Up to Date, so you can review this on your own at another time. But really the differential for low back pain falls, I think, into 3 main areas. Probably the most common is what would be considered mechanical low back pain. So that would be the lumbar strain, you lifted a heavy box, you twisted funny, ow, you get low back pain. Degenerative changes of the spine, of which many of us will have that as we get older, herniated discs, spinal stenosis, fractures, and then, of course, there are several congenital mechanical low back pain changes. The non-mechanical spine disease really, and the visceral disease are the areas that we would be more concerned and want to make sure that we aren't missing on our differentials and our evaluations. And so the non-mechanical, that's when you're thinking about, could this be either a primary or a metastatic cancer, a neoplasia? Could there be an infection within the disc or actually in the bone? The inflammatory arthritides, such as ankylosing spondylitis, reactive arthritis, rheumatoid arthritis, all of those can have findings in the spine. And then there is referred pain from a different area that is in close proximity to the spine, which could include the pelvic organs, the abdominal organs, the renal condition, aneurysms. And so you do need to make sure that when you take your history, you ask questions about those systems to see if this could be actually referred pain from something that actually is not related to the spine at all, but is in the visceral area of the body. Next slide. So let's start with case one. So this is a 40-year-old gentleman. He comes to clinic and he's got some low back pain. He's got a very physical job working in construction. And he states his back pain started about 3 days ago. He's been taking acetaminophen and doesn't feel that it's helping. And he's got, some pain into the buttock area, so he's concerned. And so what are some of the key questions that you might want to ask and find out about for this? So type into the chat if there's any specific questions. Okay, so any radicular symptoms down into the leg, okay? Is it just in the buttock or does the pain go down further? Anybody else want to type any questions they might want to ask? Okay, has there been any injury? Right, did he fall from a ladder in his job? Did anything happen? Did he notice something immediately after he lifted? Or maybe he hit something? Okay, let's go to the next slide, please. So I put this slide in for two reasons. One, and I don't know if your systems actually have a device when you try to order imaging, especially for backs or necks, that it actually helps you by pulling up some of the red flag symptoms that you should be asking with anybody who comes in with back pain. And so some of the questions are, has there been any trauma? Was there fall? Because again, that may mean that you should get imaging in that situation. Is there any motor deficit? So that would also be by history as well as your physical exam. Is there a strong suspicion of systemic disease? Is there fever, chills, sweats? Is there, again, any abdominal discomfort? Are there any upper motor neuron findings in whichever region? Is there cauda equina, loss of control over bowel or bladder, numbness in the genital area, neurogenic claudication? And so just a little bit of radiation of pain into the buttock or the thigh may not qualify as claudication. It may just be some mild radicular pain. But this is really helpful. And again, this also helps you that if there are no red flag symptoms, maybe you don't need to be ordering that MRI just about now. Next slide, please. So what I like to say is, so your history really should be very encompassing of the different systems. So it should be mechanical, it should be neurologic, it should be muscle, and it should be the abdominal pelvic area, especially if we're talking low back pain. So you might even need to ask questions about urinary symptoms or sexual function and things like that to know, is there any changes on the history? And then when you do your physical exam, I recommend that they should be in a gown. The pants should be off. It's very interesting to me. Many times I'll come into a room and a patient will either be fully clothed or they'll still have their pants on, but their back pain is low. You have to see the muscles of the legs. You have to be able to do your neurologic exam. You have to be able to do your reflexes, and that all has to be done without clothing on. So that's just something to be aware of. You do want to look at the skin to make sure we're not missing something that actually could be related to what's going on. You want to palpate the spine and the paraspinous area for any point tenderness, any changes that you may see against that. You're going to look for any atrophy of muscles or muscle groups. And then you want to do your strength evaluation, your deep tendon reflexes. You want to check their gait, straight leg racing, heel and toe walking. And then I also make sure I do a complete abdominal exam and feel for any masses or discomfort, lymphadenopathy, and make sure you're also checking pulses because, again, neurogenic claudication could be from a neurologic issue, or it could actually be real claudication and it's actually a vascular issue. I put in this video because some prior participants in this talk really wanted to see, well, how would you actually do the exam? So it's not a long video, but I think it does a nice job going through a low back pain examination, and it's from Stanford Hospital. Next slide. Okay, and then when we're thinking of doing the nerve root testing, just a reminder as to where pain radiates from which lumbar nerve root. So L4, the pain should radiate to the front of the thigh. The L5 or S1, what we might consider more in the sciatic, radiates in the back, down the buttock, down all the way below the knee, typically. And remember, the knee jerk reflex is actually for L4. The ankle is for S1, and L5 doesn't really have one of those associated with it. Next slide, please. So you get through all your history, and he does not have any red flags. He did not fall. Aside from the acetaminophen, he hasn't taken any other meds. And you do your entire exam, and it is actually normal. And so just again, type into the chat. The big question is, does he or does he not need imaging? And if not, what would you want to do? I'll wait a second. Okay. All right. All of you have this. No, he does not. No red flag symptoms. Acute mechanical low back pain does not need imaging at this time. So conservative management is the appropriate answer. Next slide, please. And so there are many, many studies. I've just listed a few of them here. Again, going to the high value care and including the high value care resources on several specialty societies. In non-specific low back pain without any risk factors or red flags, you do not need to obtain imaging. So that's been studied and you don't need to do it. Next slide. So when you think about high value care, you kind of want to answer, and this could be for any study, any condition that you're thinking about. Think about, why am I ordering this test? What do I think my differential is? And how is this test going to help me with that? And is this the most appropriate test and cost-effective test to order? So sometimes the most appropriate and cost-effective test actually might be the more expensive test because that's going to give us more information for diagnosing that particular problem. What am I going to do with the results when I get them? If I already know what my plan is going to be, and the imaging may or may not change anything I'm doing, then why do I need to do it now? And what am I going to do with the results? And how will it change my management? And then you do always need to think about the potential harms of any test. And again, weighing the benefit of doing that study with the potential harm of the procedure. Next slide, please. Again, here are some more studies about diagnostic imaging for high value. Again, this is a study that was a meta-analysis of randomized controlled trials, not very many patients, but 1,800. And what they did find is that, again, outcomes were no better between the two groups. They were basically the same. Most patients improved at 4 to 8 weeks, which is true of most acute mechanical low back pain. It didn't affect the treatment plan, whether you got imaging or did not. There may have been a little bit higher satisfaction in imaging. However, the downsides were, number one, the radiation for doing imaging, and then the labeling of somebody. And those who got imaging had more back surgery, and that creates its own issues, whether they really needed back surgery or not, creates its own discussion. I am not a surgeon, so I will not talk about the benefits of back surgery or harms with those. Next slide. So despite the fact that we all know this, we're still ordering studies that may not be necessary. And about 40% of family practice and 13% of internal medicine physicians will order a study, an imaging study for routine pain without red flags or physical findings. And again, a lot of people would order imaging in a setting of having just some sciatic pain, again, without any other red flags or physical findings. Next slide. And this was a study that actually came out of Washington State that really looked at disability with back pain. And again, looking at those who got early imaging versus standard care, physical therapy, working with, the occupational therapy, but without imaging. And again, there was really no difference in terms of the recovery. However, those that got MRI actually had longer disability, even though the outcomes in terms of function were actually the same. Again, that could go and speak to the labeling portion of this. Next slide, please. And I think this study is really, really important to just be aware of. This is actually a study that was done at a Veterans Administration hospital. And it was actually done on people who were there for non-back pain related issues. They took, these were all men. They were all over the age of 50, 148, and they just did an MRI on all of them. And what they found was that 83% had what they call signal loss, disc 2 signal loss on MRI, disc height loss. There was disc bulging, there were tears, there were protrusions. And their take home from this study was that findings on MRI are very, very common as we get older. And that does not necessarily mean that those findings actually are associated with pain or with any etiology for why people may have acute low back pain. So again, very common to have findings as we get older. Most of us will have some change if we are over 50, if we were all to get MRI'd, which I do not recommend. Next slide, please. So get back into our case. We've got normal exam. And so what management? So we decided we don't need to image him, but how are you going to manage him? Let's go to the next slide. And so what do you think? Which one has the best data for first-line therapy for low back pain? So A, B, C, or D, again, you can just type into chat which one you think is most appropriate. Okay, great. Most of you are choosing the appropriate management. Anti-inflammatories actually have the best data, even though it still would be considered moderate data. And the other ones really don't have any. Next slide, please. So let's look at some of those studies. Next slide. So again, these come from a lot of those studies that I showed you earlier by Chu and others, Deo, a lot of them published in Annals of Internal Medicine. And really what they tried to do is identify how effective the management is of the pain. So again, I'm talking pain, not function, and that we can talk about some of the differences between those. But again, for acute and chronic, and herein lies some of the problem with these studies, is a lot of the studies sort of mixed acute, subacute, and chronic pain. So it may be very hard to tease out anything that is more than a moderate effect for any one type of pain. But again, anti-inflammatories came out on top, but sometimes they did have some inconsistent results as well. Of opioids, even though opioids are normally not recommended, there was some benefit to tramadol, which is an opioid, and it did help some with pain, but it did not actually help with function. The anti-inflammatories had some pain benefit as well as some function benefit. And in the no effect to minimal effect, really that's where a lot of the other drugs that you may see being used really have not actually found in these studies to be all that effective. And I especially wanted to point out skeletal muscle relaxants. We tend to use these a lot. And I'm not even talking about the benzodiazepines, which we should not be using. But, things like methocarbamol, and those types, tizanidine, those types of medications really did not show very highly an effectiveness for either pain or function control. Sometimes we may use those, let's say the pain's so bad they're not sleeping. Where these may have the most slight benefit is actually for helping them sleep, because most of them are sedating medications. But again, not a lot of data to support them. The tricyclics, the SSRI, steroids, and opioids especially really have minimal to no effect in terms of effect on the pain and function. Next slide. And so again, harms, obviously a lot of harms potential. Opioids, there's significant harm. The benzodiazepines, also because they're sedating, they can also increase risk of falls. So again, we don't want that. We don't want people more impaired because that actually could put them up for actually worsening back pain by falling or injuring themselves. Next slide, please. And again, some of the non-pharmacologic things, again, still moderate to low evidence, but the things that have found to have the more benefit are using heat. So that could be a heating pad, getting into a warm shower, things like that. They did not actually study any of the topical agents for any of the studies I'm presenting. So that's sort of an unknown really in terms of data. It's maybe something to consider trying. The topical agents, Icy Hot and Salon Pot, some of those other ones, but again, very little data that is available for acute low back pain. Low to moderate low exercise. And that probably is really critical to actually keep people moving. And some level, you don't want them to go getting on treadmills, jogging, Zumba, but maybe just a little bit of walking. Maybe it's physical therapy, working with somebody to just work on sort of core strength, body mechanics, some gentle activity. You have to be a little careful with yoga, I think. And again, that was in the low group, just because sometimes yoga, if not done properly, actually can cause some injury to people. Acupuncture actually has some relatively good data. I should say low to moderate, but a little better than some of the others. So again, for pain management, that may be something to consider. Next slide, please. And again, almost all of the guidelines that you will see for management of back pain will include some graded exercise. Acupuncture, again, I just wanted to point out a couple of those studies so you have those references for you, and showed a little bit more benefit than no treatment at all. Next slide. Again, very few studies actually even commented on harms of non-pharma, but most of these are relatively lower risk interventions anyways. I think you have to be a little careful with spinal manipulation, again, depending on the quality of the people who are doing it. And I think there are some differences when you're talking about spinal manipulation of the low back pain versus the neck. You have to be a little bit more careful about neck. Next slide, please. And again, we really don't have great data in terms of what's the better treatment for a radicular. So those are where, yeah, low back pain, a little radiation down into one leg. They didn't tease those out in the study, so it actually makes it very hard. And we also don't have a lot of data on in terms of disability outcomes, like how quickly people improve and for how long are they disabled for? Next slide, please. Okay, so let's go to the next case. This is a 72-year-old, comes to clinic with severe low back pain. She slipped off her bed and landed on her buttock yesterday or last night, and the pain is located to one area of the low spine. The other red flags are negative. She does have some tenderness over that area. And so here I would like to ask, is this a case that you might consider getting imaging for? Just yes or no in the chat. So most people would, and I would say, yes, this would be reasonable. And the imaging you could get is just a plain X-ray of the lumbar spine. Next slide. So yes, it doesn't need to be an MRI unless you have other findings that you feel you would need to get an MRI. So that would be other red flag findings or neurologic findings or something else that would make you think you needed to go to that. But an X-ray of the spine, if you're thinking this could be a compression fracture should show up on that. Next slide. And so this is what it might look like. Normally, if you see the X-ray, you're not going to get the radiology sign, but for purposes of this talk, there it is. That's a compression fracture in the lumbar spine. Next slide. And so again, these are common. It doesn't actually take a lot of injury, so little slips and falls that older people can get. Again, you do want to do assessments for osteoporosis and treat that appropriately. And management would be some, again, pain management, anti-inflammatories, if they're able to take those still, probably the better choice. You really want to try to avoid opioids or benzos or anything that would sedate them. Again, that could increase their risk of falling, confusion, and things like that. And then, of course, these are people who I definitely would try to get to some kind of back pain, spine program, physical therapy, gentle exercise, because again, you don't want to be too aggressive while they're trying to heal from that immediate fracture. And help them again to prevent further falling. That is critical for this. Next slide, please. So third case, this is a 55-year-old male, and he presents with fatigue and sudden back pain. He describes this as severe and persistent. It's not getting better with lying down. He's tried different oral over-the-counter medications, including acetaminophen and anti-inflammatories. He looks a little pale on exam when you look at his mucous membrane. Neurologic exam appears to be intact, and he has no tenderness on the palpation. Next slide. So yes, so clearly with this sort of thing, acute, really no other finding except he's pale. So again, now you're thinking, could there be some systematic or systemic issue going on? And you want to do some other studies here to try to determine what could be going on. So you get a complete blood count, you might get a complete metabolic panel, you get a sedimentation rate and maybe a CRP, and these are abnormal. And so let's go to the next slide. So what we want to think about is, yes, so now we're thinking, this could be something bad. And then it falls into that category of non-mechanical systemic conditions. So those could be malignancies, the rheumatologic conditions, and things like that. The sedimentation rate has a good sensitivity when it's low, but it's not very specific. So it could be high, but it could be high in all kinds of different things. If you get a much higher sedimentation rate, an ESR, even though the sensitivity is not very good, meaning a lot of people with that condition may not have a high ESR. If they do have it, then you are very likely going to be having some underlying problem there. And you need to go figure out what that is. So by that, he had a 65. So again, over 95% specificity that there is going to be a cancer or some other systemic issue causing that problem. Also, findings of anemia in this situation have high specificity, but not very good sensitivity. So again, if they're present, that's helpful. If they're absent, it doesn't rule it out. So that's just something to be aware of. So if present, keep going. Absent, you may still need to keep going because the test isn't helping rule it out. Next slide, please. This is quite a busy slide. Again, I just want to point this out because it's in up to date. And this really is a algorithm that can help you determine, do I or do I not need to be getting imaging? Let's go to the next slide, please. And so if you did a skull series or bone series on this person, you might see these punched out lesions, these lytic lesions in the brain. And so this is fairly classic looking for multiple myeloma. This may be absent in your patient, but it would mean you would want to get them to a specialist probably as soon as possible to, again, do the bone marrow aspiration and get the definitive diagnosis and get them started on appropriate treatment. Next slide, please. So yes, a lot of malignancies can go to the bone, renal cancers, multiple myeloma, lung cancers, breast cancers, prostate cancers, and even some of the thyroid. If they metastasize, they tend to metastasize a lot to bone and other organs. Next slide. Okay, I'm going to go through all the cases and then we'll have time at the end for questions. I see there's a couple that are in the Q&A. So the fourth case, this is a 60-year-old who comes to clinic and now he's got severe low back pain. It feels like it's on fire, burning. Started about a week ago. Again, tried all the over-the-counter things that he could think of. Excuse me. There are no other red flags. And you have the patient undress. And on the back, you notice, next slide, this. So everybody probably recognizes this. You can type it into the chat if you do. Yes, so this is shingles, herpes zoster, single dermatome, and many people can present. And these, we all get confused by these patients because the pain typically precedes the lesions, and the pain can be severe. So it tends to be single dermatome. So they may say, you know, just hurts right along here. And I can't, nothing I do gets rid of it. Seems to be unilateral. And until you see the rash, it is sometimes very, very, very almost impossible to diagnose this without the rash. So I look very carefully for rash. Even one little dot could help me make that diagnosis and get them started on treatment sooner. Next slide. We all know that shingles or herpes zoster, varicella zoster reactivation. Usually it's a single dermatome. If it is multidermatomal, you should be looking for underlying immune compromise conditions. This can increase a risk with age. Obviously, we would recommend making sure your patients are vaccinated with the Shingrix vaccine, which is recommended for anybody over 50. And again, you would want to treat the shingles, the rash with either acyclovir or valcyclovir. Again, the treatment of pain, even though these may not work great, there's probably a little bit more data to use things like tricyclics and gabapentin. Start with low dose because these are very sedating, especially in older people, and can have a lot of side effects. So you need to be a little careful with these meds. Next slide. Okay, our case 5, this is a 22-year-old. He's coming in with low back pain. The pain seems to be worse in the morning, better with exercise, no other red flags, signs, or symptoms. The exam is normal, and you're really putting him through the exercises. You send him to physical therapy. It helped a little bit, but then after 6 weeks, he still has the pain. Now you decided you're going to do some plain x-rays and they're normal. So what else might you think about in the differential for this individual? And I'll give you a minute to type some options in the chat. Okay. So one brave person mentioned ankylosing spondylitis. Yes, so definitely you want, now you're thinking something else could be going on. This is a young person, really no risk factors. Why are they having kind of this constant low back pain, worse in the morning, where usually general musculoskeletal pain gets better after you rest overnight, and his gets better with exercise. Next slide, please. Yeah, so now you're thinking, could this be some underlying rheumatologic? You may still want to think about malignancy. In a young person, there are certain malignancies that could have things go to the back. So, checking testicular exam and things like that may be important. But here you may really be thinking about, could they have one of the rheumatologic conditions that can give or cause back pain? And ankylosing spondylitis is probably one of the more common ones to affect the axial skeleton, and usually presents at a young age, so usually before the age of 40. You may want to ask about, has there been any other symptoms that they may have had? And it does not have to be at the same time as the pain. So these could be things that could have occurred in the past. They didn't know about it. Maybe they got treated and there was no connection made. Diagnosis, yes, you can take family history. Your diagnosis would still be the inflammatory markers, your HLA-B 27, and then you may want to get a specific MRI to look at the SI joints to see if there's any inflammation on those. So plain films early on probably aren't going to show anything. So here's where you may actually need to go to further imaging. And then you really want to get these people into early rheumatologic care to get on medications, disease-modifying medications, so they do not go on to, next slide, to get what is called a bamboo spine. So this is what happens if you have ongoing inflammation in there, that you just kind of get, basically a spine that becomes really rigid, that looks like a piece of bamboo. That's how it got its name. And now these people have chronic back pain as well as decreased mobility and other issues. So we want to try to prevent this from happening. Next slide. Okay, so this is going to be our last case, and then we'll go to questions. 85-year-old presents with low back pain and pain that radiates to the legs. Seems to be worse with walking, better with rest. He feels better when, when you kind of bend over or stops and bends over a chair or a bench. He's got some kyphosis. His pulses, and you do a really good job checking those, appear to be normal and symmetric on the lower extremity. There does not appear to be any edema, and the remainder of the neurologic exam appears normal. He does kind of walk sort of gently and funny, but without any shuffling gait or foot drop or anything else. And you did do some plain x-rays. Next slide. And you see sort of this kind of thickening type of picture associated with that. Next slide. And so again, some things that you may see, again, this comes from UpToDate, so you can look at this in more detail. That picture A on top is what a normal anatomy of the disc should look like. And again, when you start to get chronic changes, you start to get thickening, which is what you saw in the x-ray, that thickening of the ligamentum. You may have some herniation of the discs. You may get what's called some spondylolysis, some movement. And again, there's variations on how much is dangerous. And those are things you should talk to your radiologist about. But this is really a classic presentation of spinal stenosis. Next slide, please. And again, spinal stenosis also more common as we get older, and it really is a narrowing of the spine. It can put pressure on the nerves, usually because of the thickening of the ligaments. So there can be some neurologic abnormalities. And so if it is significant or severe, then these are people who may need to get referred to a specialist in spine, maybe even somebody talking to somebody in neurosurgery for spine surgery, depending on how significant it is. And again, classic is sort of, it gets worse when they walk, sort of this pseudo-claudication, and usually down into the legs, that their legs just start hurting when they start walking. And you must distinguish this from vascular claudication. And so sometimes if you're not sure, you may want to actually get an arterial, a Doppler arterial study of the lower extremity, starting at the groin as well. You can have both actually. So that would be important to make sure. And then again, here you want to do appropriate pain management. Again, opioids really don't work all that well. You want to do, again, balance, some very gentle physical therapy. And again, even though, again, I don't do steroid injections or surgery, but again, these are where you may need to be referring for some additional therapy just to help out with symptom management. Next slide, please. So just kind of reviewing some of our key points. Low back pain, very common. Very common. Most of it, a lot of it is mechanical low back pain. But we do really, really want to make sure that we look for those red flags to identify those that may need imaging, that may need other studies, because we don't want to miss some of those things. But general acute mechanical low back pain really can be managed conservatively with heat, anti-inflammatories, gentle movement. You really want to try to avoid narcotics for these patients. And again, most of the data supports not using opioids for that. Next slide, I gave you several references. There were also some that were in the body of the talk as well. And now we can stop sharing the slides, and why don't we see if there's any specific questions that people may have. Oh, those weren't questions in the Q&A. Are there any questions that anybody has?
Same. Just make sure we don't see anything. Yep. So if you have any questions, you can put them in the Q&A box, chat box, use the raise hand feature. While we're waiting for your questions, I'll remind you that the CME survey is going to appear in your on your browser in a tab. You can click on that. If you complete it correctly, you'll receive it almost immediately. And while we're waiting, we are also in the middle of our annual provider survey. So as a clinician at one of our clinics, you have the opportunity once a year to give us feedback, tell us all the things that you'd like us to know, what to plan for, tell us how great our educational sessions are, or not, but we'll go with positive. We really do appreciate anybody that can complete this feedback, this survey. So in addition to your CME survey, I'm going to put this link in your chat. We would really appreciate it if you do. We have until Monday, the 23rd to complete that survey. Question.
Okay. Yeah, so thank you. There was a question on, yes, I would recommend reviewing the quick video. It's only 8 minutes on the back pain. So my quick takes are, if I know someone is coming in with back pain, I actually like to see, if I can, if it works out, I like to see them walk from the waiting room to the exam room. So first of all, they don't know I'm observing them. So that actually starts my exam on them. So if I see them walking and how they're being put into the room, that's really helpful. Again, I usually, if I know it's for low back pain, I really try to have my MA efficiently already get them in a gown. They can leave underwear on, but in a gown, so I actually can be efficient in terms of my exam. And then I start with kind of the general inspection, palpation. I usually will do my muscle strength testing with them sitting on the bed, as well as my deep tendon reflexes, and doing all that. And then the abdominal exam, then I actually will get them up. If I haven't seen them walk or move before, I will get them up and I will see how they walk in the room. I may look at their balance. I will see, can they balance on one foot? Can they do heel and toe walking? So with good practice, really a exam probably should not take you more than maybe 5 or 6 minutes to do all of those things. So I'm not sure if that answered your question, Cindy. And hopefully that will be helpful. And I think I would watch the video because, again, the teaching video takes 8 minutes. So they're teaching, so you know that doing it in real time probably is a little less than that in your own practices. No open questions, so thank you. Yeah.
That's helpful.
I'm glad that helps to confirm.
Yes.
Yeah.
All right. And yes, there's a question about the slides. As we mentioned, at all of our Maven project sessions, you are recorded and you will receive the slides 24 hours from now in an email from Zoom. Also in that email, we'll have your CME survey link. All right. Well, I don't see any other questions, but we'll pause and we'll wait.
Oh, okay.
So any
Any
last
other
minute?
questions? I will give you 15 minutes back on your time.
All right.
That if there's no other questions, and I
I-
really want to thank you for your attention and
And
have good holidays, everybody.
thank you so much, Dr. Horwitch. This was great. Have a great day, everyone.